Welcome to the deep dive. Today, we are wrestling with one of the biggest questions out there about the UK's National Health Service. Why doesn't the NHS just train more doctors? You hear it all the time, and it sounds so simple, right? Just the most intuitive fix.
It seemed obvious.
But when we pulled this stack of sources, the answer wasn't, a simple budget issue. It pointed to something much deeper, a profound structural failure.
Exactly.
So our mission today is really to cut through that intuition and reveal the hidden costs, the fragmented responsibilities, and just the sheer engineering it would take to fix this.
Yeah, this deep dive past any idea of moral failure or simple incompetence really quickly.
Right.
What we found is a sophisticated problem. It's rooted in fragmented responsibility and, crucially, massive hidden economic costs that have built up over decades.
So we're going to analyze the gap between the true cost of long-term investment and the quiet, persistent cost of not planning at all.
It's a study in the failures of the short political time horizon.
Okay, let's unpack this. We have to start, I think, by clearing away the biggest misconception first. This idea that the crisis gripping the NHS just arrived suddenly, that the pressure was a total surprise.
It's a convenient narrative, isn't it? The sudden crisis.
Yeah.
But the material makes it absolutely painfully clear that the system has been under intensifying pressure for decades. And the rise in demand, it was completely foreseeable.
So it didn't just arise out of nowhere?
Not at all. It's a systemic collapse that was telegraphed years ago.
So, okay, if we accept it wasn't a failure of prediction, I mean, they weren't using tea leaves, they had data. What were the obvious signs the system just ignored?
Well, the sources outline 5 main structural factors, 5 drivers for that steady, relentless increase in demand, and all of them were visible in demographic data years, even decades, in advance.
This isn't theoretical stuff.
No, this is standard population modeling.
Give us the list. What were those 5 obvious drivers?
Okay, so first and foremost, you have the simple, inescapable math of an aging population. People are living longer, which is great, but that naturally increases the burden on health services.
Okay, makes sense.
Second, and this is related, more people are living longer with multiple chronic diseases, complex diabetes, heart failure, respiratory issues. Managing all of that takes exponentially more clinical time.
But that makes perfect sense. We're not just treating people for a broken leg anymore.
Precisely. We're managing their total long-term health complexity.
What's third?
Third is expanded diagnostics and treatment expectations. Every year, medicine advances. We can now treat conditions that were, untreatable 20 years ago, and the public, rightly so, expects access to those new treatments.
Sure. And the fourth?
Fourth was a conscious policy decision, the implementation of 7-day services in hospitals.
Which is great for patient care.
Fantastic for patient care, but it requires significantly more total staff to maintain safety 24/7. You can't just spread 5 days of staff over 7 days.
And the fifth one, I suspect this is the one that frustrates clinicians the most.
Oh, it is. It's the increased regulatory and administrative load on every single clinician. The documentation, the mandatory training, auditing, governance.
All necessary for safety, I get that, but
But they steal crucial hours from patient care and from supervision.
when you lay all 5 of those out, it's a tidal wave. It wasn't a failure to see the future. It was a failure to act early enough.
And that's the ultimate paradox.
Especially given the timeline. The sources are so sobering here. It takes, a minimum of 10 to 15 years to train a doctor? From start to finish?
10 to 15 years. The only solution that truly fixes the problem takes longer than the lifespan of almost any political administration or budget cycle. That delay loop, that's the real killer.
So this brings us to the structural core of it all. If everyone knew this was coming, why did nothing happen? We assume there's some big bureaucracy making the call, but who is the actual they that failed?
That's the critical conceptual nugget from this deep dive. The reason for the failure isn't some central villain, it's a decentralized paralysis.
There isn't a single doctor number dial that someone can just turn up.
No. The sources show there is no single day. Responsibility is fragmented across 6 different, often competing institutional levers.
6 levers. I think that's a perfect analogy because no one person can pull all 6 at once. Walk us through that chain. Who controls what?
You start right at the top with the Treasury. They hold the purse strings. They decide how much money is available for everything.
Okay.
So the number of doctors trained ultimately depends on the money they allocate.
Then you move down to the Department of Health, and they decide how to carve up that allocation. How much goes to services versus training?
And crucially, below them is NHS England. Now, they don't run the medical schools, but they fund the actual postgraduate training posts.
The jobs where doctors specialize in hospitals.
Exactly. You can
That.
graduate 10,000 students, but if there are only 8,000 funded specialty posts, 2,000 just can't progress.
And then you have the universities themselves. They're limited by the number of funded places the government gives them. They turn away thousands of qualified UK applicants every
Single year. Because they simply don't have the funded spots.
And we can't forget the regulators, like the General Medical Council.
Right, the GMC. They're crucial. They set the standards. They tell you how good a doctor must be to qualify, but they don't set the number of doctors to be trained.
And finally, the doctors' unions. They fight for pay and conditions, but they can't magically create training posts or funding.
And what's fascinating here is that every professional body, every workforce analyst, the people who did have the long-term view, they spent years warning about this.
Publicly.
Highlighting the UK's dangerously low doctor-per-head ratios compared to, say, Germany or France. The unsustainable reliance on overseas recruitment.
But their warnings just fell into the gaps between those institutions.
Exactly. They couldn't enact the change, and the institutions that could just didn't have that 15-year perspective.
So we ended up with a system structurally incapable of doing the right long-term thing. And when faced with those empty rotas and rising demand, what did it do?
It defaulted to the fastest, cheapest, simplest lever.
International recruitment.
Absolutely. And again, just to be really clear, this is not a criticism of the individual doctors who come here. They're often highly skilled, dedicated, and they've been essential to keeping the NHS afloat.
This is an economic and a resilience issue, a consequence of that structural failure.
Yes. And the scale of that reliance is massive. The sources show that today, roughly 40% of licensed doctors in the UK trained overseas.
40%. And that's about double what you see in comparable wealthy countries.
Right. And that 40% figure creates what the sources call a huge economic anchoring problem that is, well, it's rarely discussed.
This is where we shift from staffing to, economic geography.
Pretty much. The concept is resilience based on economic anchoring. People who expect to settle long-term, the true economic anchors, they do things like buy homes, invest in local schools, spend on local services.
Their money circulates. It contributes to domestic growth.
But the reality of a highly mobile, internationally recruited workforce is that many people arrive intending to work for a fixed period before moving on, maybe back home or to another country.
And they behave differently with their money.
Fundamentally differently. They tend to remit income overseas, save aggressively towards an exit, and minimize their spending in the domestic market. Again, neither behavior is right or wrong, but the collective economic effects are radically different. The country misses the multiplier effect.
Okay, let's talk scale. The sources offer a quick calculation, kind of back-of-a-fag packet math, to estimate this economic leakage.
Yeah, and the point here isn't the exact audit trail, it's the sheer magnitude.
Okay, so let's use conservative figures. 40% of the workforce trained overseas. But let's assume only half of them, say 20% of the total doctor workforce, are in that phase of aggressive saving or remitting.
So that's roughly 65,000 doctors whose primary financial orientation is, well, external.
And if we use a deliberately low salary, say an entry-level doctor at £36,000 a year, that cohort represents an annual pay pool of about £2.4 billion.
Now, the quick model suggests that if that group remits or saves, say 10 to 30% of their pay, we are talking about 240 million to 720 million pounds leaving the UK economy every year.
Wow. Money that isn't flowing through housing or childcare or local shops.
Exactly. But the real scale comes when you apply the economic multiplier.
Right, because money spent locally gets spent again.
The sources use a modest multiplier, maybe 1.3 to 1.7. When you apply that, the total lost domestic demand ranges from roughly 300 million up to potentially 1.2 billion pounds.
Every single year.
Every single year. That range, hundreds of millions to over $1 billion, that sets the scale of the system's resilience deficit. It's the cost of the short-term fix crystallized into a permanent annual drag on the domestic economy.
We are essentially exporting the economic benefit of their labor.
In a way, yes.
Which finally brings us to the core solution. If we know the cost of not planning is massive, what would it actually cost to do it right, to execute the long-term engineering solution?
The source material breaks this down into two distinct goals: Stabilization versus repair.
Okay, what's stabilization?
Stabilization is just damage control. It means meeting the expected new demand from those 5 drivers we talked about, just so things don't get any worse.
Just to keep pace.
Exactly. Most credible models suggest we need 4,000 to 5,000 additional UK-trained doctors per year just to stabilize staffing.
And the cost of that, the all-in cost to train one doctor, is estimated at, what, 250,000 pounds spread out over years.
Correct. So once that new system is fully running, which takes 15 years to get the pipeline full, the steady-state annual cost for stabilization alone is roughly 1 to 1.5 billion pounds a year.
And that's just to stop things getting worse.
That is just to prevent further deterioration.
So if we only stabilize, we are permanently locking in that deficit, that 40% reliance, the economic leakage, all of it. We stabilize a fragile system, but we haven't repaired it.
Exactly. Repair is the much harder long-term goal. Repair means gradually reducing that 40% reliance down towards the 20 to 25% you see in other countries.
And to do that, we have to unwind an inherited deficit of 50 to 70,000 doctors.
And the sources suggest this has to be done on a glide path over 20 to 25 years. So you need to train an additional 2,000 to 3,000 UK-trained doctors per year on top of the stabilization numbers.
So the full, comprehensive long-term repair plan requires a total of 6,000 to 8,000 extra UK-trained doctors per year.
Sustained for over 2 decades, it's a huge commitment, but it's also a massive long-term employment and skills policy. You're creating up to 200,000 additional UK-trained professionals.
And the total investment for that full repair.
It lands at 1.5 to 2.25 billion pounds per year. But crucially, the sources put this cost into sharp context. It's actually small compared to the total NHS budget, and even small compared to the cost of economic leakage and agency fees we calculated earlier.
And to make that scale tangible for you, the listener, the full repair cost works out to roughly 55 to 80 pounds per household per year.
Or about 3/4 of a penny to 1 penny on the basic rate of income tax.
This is spending now to stop paying forever.
It shifts the expenditure from a recurring cost of failure agency staff, high churn leakage, to an infrastructure investment in training capacity and local employment.
Okay, here's the real paradox, though, and this is where it gets truly fascinating. If the cost is relatively small, less than a penny on tax, and the motivation to save the NHS is huge, why haven't they done it? The bottleneck isn't the young people. Medicine is massively oversubscribed.
Qualified UK applicants are turned away every year.
So what's the real choke point?
This is the crux of it. The capacity issue isn't the medical school lecture hall. That's relatively cheap to scale. The real choke point is downstream. It's postgraduate training posts, and critically, the senior capacity needed to supervise new doctors safely.
Wait, so you're telling me we have to turn away qualified UK students because we don't have enough senior doctors with available time to watch them work?
That's it, exactly. You can't train a junior doctor unless there is a senior clinician, a consultant, or a GP who is funded and scheduled to dedicate time to supervision, to teaching. And when the rotas are already thin, the first thing to get squeezed is that protected teaching time.
And that creates the ultimate negative feedback loop.
A vicious cycle, yeah.
We need more senior doctors to supervise, but we can't create them because we don't have enough supervision capacity right now.
The virtuous cycle would be train more doctors, more stay, more become senior clinicians. You get more supervision capacity, which allows for more training posts, which lets you train even more. We need to intentionally engineer that initial push to break out of the negative loop we're in.
And this structural shortage is then amplified by the private health sector.
Absolutely. The material notes the asymmetry. Private providers generally don't train doctors. They recruit from the finite pool that the NHS paid to create.
Right.
So, in a system where supply is critically tight, private providers can easily outbid the NHS for marginal hours, like weekend cover or specific procedures.
So the NHS carries the decades-long cost of training and supervision, while the private market extracts the finished capacity once the shortages already exist.
Which effectively leads to a hollowing out of the NHS workforce during its busiest, most stressed periods. Private healthcare isn't inherently bad, but operating atop a chronically undertrained, state-funded system, it just drains its resilience.
We should also address the common counter-argument, right? That UK-trained doctors also leave the country.
Yeah, the sources clarify that. The difference is pattern, not purity.
It's not about zero loss. It's about the timing and the economic impact.
Exactly. Most UK-trained doctors spend the bulk of their careers working here. paying taxes, spending locally for years, maybe decades, before they might move abroad. That is fundamentally different economically from a system where a massive chunk of the workforce is highly mobile and arrives already intending to remit income.
The flows just aren't symmetrical.
Not in their scale or their domestic economic benefit, no.
This whole deep dive just underscores a simple, profound truth. It's not just that we're suffering from a doctor shortage.
It's that we are paying twice. Once for the healthcare we receive and once for our decades-long failure to plan. And we are paying that second premium price every single year in leakage, agency costs, and reduced productivity.
And that distinction between stabilization and repair is essential. Stabilization, just meeting new demand, will never solve the inherited deficit.
Never. Resilience requires treating training and supervision as core national infrastructure, planning to ratios, recalibrating regularly.
The cost of the full repair, that $1.5 to $2.25 billion a year, it's small relative to the cost of the structural deficit we currently just accept.
Which suggests the core problem isn't one of affordability, it's one of political time horizon. No politician wants to invest now in a solution that pays off 15 years after they've left office.
Which leaves us with this final thought for you. The only way out of this systemic failure requires long-term engineering, not short-term renovation. So knowing this, look at the systemic areas in your own professional or private life. Your budget, your career, your personal infrastructure. What are you currently stabilizing when deep down you know you should be committing to deep, patient, long-term repair? Something to chew on until the next time.